Welcome to this free anaesthetic tutorial on ketamine. As always, we will run through our standardized mnemonic for running through any drug question in the exam. We will begin with chemical, then uses, presentation and dosing, actions and mechanism, followed by pharmacodynamics, pharmacokinetics, and ending with special characteristics. Chemical. Ketamine is a phencyclidine derivative. It causes dissociative anaesthesia, meaning that it reduces the signals to the conscious mind from other parts of the brain, such as the senses, and so reduces memory formation. It exhibits stereoisomerism in the form of R and S-ketamine, and this is a very common SOE topic, and one that will be covered in a future free anaesthetic tutorial, so do stay tuned for that. Uses. It is used for intravenous induction and appears to have a particular place in the management of pre-hospital and intra-hospital trauma patients requiring anaesthesia. It is a potent analgesic and can be used in acute or chronic pain. It can be used in life-threatening asthma when initial therapies have failed. Presentation. It is presented as a colourless, slightly acidic solution in a glass vial and can be found in a number of concentrations. It often contains a preservative that prevents intrathecal or epidural use. It is usually presented as a racemic mixture of two stereoisomers, but S-ketamine is now often used because of its favourable pharmacological properties. Dose. It is given intramuscularly in a dose of 10 mg per kilogram, and it has a reasonably quick onset time for this of 2 to 5 minutes with a duration of around 20 minutes. Its IV dose is about 1.5 to 2 mg per kilogram. It will produce unconsciousness in around 1 to 2 minutes. The onset of action is slower than other IV induction agents, and the endpoint is more difficult to judge. It can also be given by infusion, and it is unique amongst induction agents in that it can be administered intravenously, intramuscularly, orally, nasally, rectally, and it can even be given intrathecally or epidurally if the preservative-free concentration is used. Mechanism of action. Ketamine produces dissociative anaesthesia. This is a unique clinical state involving catalepsy where the eyes may remain open with a slow nystagmus, but the corneal and light reflexes remain intact. It produces anaesthesia via non-competitive antagonism of the N-methyl D-aspartate or NMDA receptor, and these are located in the brain and the spinal cord. It has hypnotic, analgesic, and local anaesthetic properties. Pharmacodynamic effects. Ketamine is a unique cardiovascular profile. It causes a rise in heart rate, blood pressure, central venous pressure, a rise in cardiac output, and also increases sympathetic tone, and this makes it a useful induction agent in shocked patients. It preserves airway reflexes and respiratory drive and can cause bronchodilation. It may also cause hypersalivation, and this may have negative effects. It has been associated with increased cerebral blood flow, increased cerebral metabolic rate of oxygen, and increased intracranial pressure. And traditionally, people have avoided ketamine in patients with head injury. Now, there is some dispute about these effects, and as time progresses, this may well be proven to be incorrect. It can cause post-operative nausea and vomiting. It can cause urinary retention, as well as increased uterine tone and increased circulating catecholamines. Toxicity. Ketamine has been associated with a rash. The emergence phenomenon is associated with alterations in mood state. It can cause floating sensations, vivid dreams and hallucinations. Generally, the emergence phenomenon is prevented with pre-medication with benzodiazepines. Ketamine can also cause significant pain on injection due to its pharmacological properties. Pharmacokinetics. Absorption. It is 20% oral bioavailability. Distribution. It is low protein binding and a reasonable volume of distribution of about 3 liters per kilogram. Metabolism. It is hepatically metabolized to active and inactive metabolites. And excretion. It is renally excreted with a clearance of about 70 milliliters per kilogram per minute and an elimination half-life of around 2.5 hours. Special points. Ketamine shouldn't be used in pregnancy, however it can be used in children. Ketamine and thiopentone are physically incompatible and shouldn't be used immediately after each other or together, and there is some debate regarding the safety profile of ketamine in porphyria. The latest anaesthetic tutorial of the week felt that it was safe in porphyria, but when you look at the BJA Education latest article, it actually argued that it was unsafe in porphyria. So at the moment, there does exist some debate between those two. Thank you for watching this free anaesthetic tutorial on ketamine. Please do be sure to have a little look at our Facebook and Instagram resources. Please do subscribe to the YouTube channel as this allows us to increase the spread of the resources, and also just allows us to continue making these resources. Please do let us know if there is anything you particularly found useful, or if you have some constructive feedback or criticism. We'd love to know, we'd love to hear from you, and please do let us know. Thanks again. See you now.